Welcome back, Health Impact audience. You guys have had a fantastic day today. We started the day off talking about how to get rid of stupid stuff. And it's been one of our most favorite sessions we've been doing this for 10 years plus, and it's been the audience's favorite session so far. We've got a lot of questions that came in after that as well. But one thing we wanted to cover is a little bit more on what is physician burden beyond the platitudes to say, hey, we should be doing better for clinicians. We all talk about it. In the morning, we say we're going to reduce burden, and then we give them a stack of stuff to do that's double what it was yesterday, right? So we're all, in many respects, BSing ourselves and BSing our clinicians and staff. And so really wanted to talk about that as a topic of hybrid healthcare has created now its own inefficiencies. It's created a lot of efficiency as well, but those new inefficiencies have created new burdens that we didn't have before, plus all the stuff that people had to do before. So that's really what we're going to center around this conversation. And we've got three, as usual, fantastic panelists and experts on the subject. We're going to get started with Aarti. Please introduce yourself, then we'll go to Judd and then to Jeet, and then I'll present my first question. Go ahead, Aarti.
Thank you, Shahid, and thanks for having me. My name is Aarti Ravi Kumar. I'm an endocrinologist still practicing, as well as I am the Chief Medical Information Officer at Atlantic Health System, a multi-hospital system in New Jersey.
Awesome. Welcome, Judd.
So I'm Judd Hollander. And first, I have to tell you, I'm entirely impressed because you began by saying the last session was on getting rid of stupid stuff, and you still left me here. So I'm honored. but I am an emergency physician, and I work at Thomas Jefferson, where I'm the Senior Vice President of Healthcare Delivery Innovation. And relevant to this panel, the telemedicine program, the urgent care centers, and some of digital health roll up to me to both oversee, as well I'm a clinician who deals with patients with those modalities.
Yeah, awesome. Jeet?
Hi, Shahid, and hi, everyone. I'm Jeet Barmich. I'm internist by training, practicing part-time hospitalist. I'm a senior vice president and chief information officer at SBH Health System in the Bronx, and I oversee information technology, data analytics, and clinical engineering. Happy to be here. And Shahid, what a wonderful opening comments.
Thanks. No, welcome all of you. And really, maybe if we kind of frame the discussion, so many of us are techies in the audience and certainly on the call as well. We've heard of a term called technical debt. Technical debt is when you make a quick choice of a piece of technology, knowing that it's not the best thing you can do, and that you're supposed to pay back that technical debt, which we rarely do. And as long as you don't pay it back, you keep accruing technical interest, as it were, and it gets bigger and bigger and bigger until you have to throw the entire thing away or call bankruptcy on technology. I tend to think that that's really what we're doing with our clinicians, staff, et cetera, is we're taking clinician and staff debt. We're saying, please work with us, give us extra time, take all of this extra burden that we're putting on you, and we're going to pay you back at some time. We almost never, ever do. And that's really, I think, a challenge, is that we see the hybrid healthcare side improving patients' lives by allowing us to get care without having to come in and risk infection, et cetera. But of course, our clinician colleagues like you all do not have that luxury. So maybe that's a good place to start out, is what are some of the common myths or misconceptions about what is clinician burden and what it isn't? Because just telling people that they're working hard may not be burden, right? So I'd love to just start with that. And Aarti, if you want to just take us off from that point and say, what do you think is burden, true burden, and what are the common myths and misconceptions associated with the clinician burden?
Sure. So I would say that, in my perspective, probably clinician burden feels like doing things that they think that that they don't need to do. So things that I feel like, for example, in a medical record, looking for data elements that could be automatically input instead of spending the time thinking through a patient's clinical history, or spending the time utilizing the training that you've done to be able to formulate a plan. So doing kind of rote things that you haven't necessarily trained for, but that you're being asked to do to be able to provide care.
Yeah, and in that regard, Aarti, then do you subscribe to the notion that if you are not removing things that people are not needing to do, that you're not actually reducing burden, right? So my fear is that whether it's the C-suite or whether it's people outside the hospitals, everybody loves to say we need to reduce burden, but nobody's actually doing something about it. And that's why the earlier talk today about removing the stupid stuff was about that. So how would you know that somebody's actually helping you reduce burden?
So for us, actually, we utilize statistics. So we actually use a physician efficiency program where we look at the amount of time that physicians are spending in the chart. And so we can say, where are you spending more time than maybe your colleagues? Where are you spending your pajama time? So your time at home, your time outside of scheduled work hours, doing work that maybe if we were to actually be able to optimize your utilization of our technology, that you would be able to reduce that. And so we actually use those individualized and personalized dashboards to set up a one-on-one session for our physicians with our training team. And we actually walk them through, like, here, we noticed that you spent 50% more time than somebody else in your practice doing this particular thing in the electronic medical record. And we'll give them useful and tangible tips and tricks as to how to reduce that. Maybe creating a smart product, maybe creating a smart phrase, maybe pulling in a preference list. And then we actually look at the metrics after the session, and we can actually see reduction in the time in the chart in those areas that we focus on, as well as we do get qualitative feedback from the physicians. And we've heard from almost every single doctor that's done this program that they found it valuable, or extremely valuable, to learn and relearn tips and tricks in the medical record to be able to optimize their time in their chart.
Got it. Great advice. So Jeet, what do you think about some common myths and misconceptions? How do you explain burden to people, maybe when they're not in the community?
So from the clinician perspective, let me give you a little bit, let's step backward. This is prior to pandemic, sorry. There has been a transition from episodic to longitudinal care. That is number one. And people are marching towards high value care, taking full risk. There is so-called information overload. So in terms of clinician burden, it's not so much of myth, but these are the facts. I mean, you can have clinician burden because of people, process, and technology. For example, if there is no enough staff for your care coordination activities, or the task which just Aarti mentioned can be done by a lower licensed professional, and if you have to do everything on your own, that is a people issue. You need to add on staffing who can do the back end work, and the front end work can be done by the clinicians. And similarly, processes, if your workflows are not re-engineered based on your clinical workflows or operational workflow, that could everything is additive in my opinion. And people tend to say technology is number one. In my opinion, it is people, process, and technology together. Sometimes you can juggle if you don't have a good user interface, or as Aarti mentioned that we did a study, actually it took about 17 clicks to get to the longitudinal results. So we had to make some changes with MLM so that the pertinent information was present at the time of the care. So these were some good feedback and how the EMR as a toolkit was designed. But again, it's a work in process. EHR is a journey itself. We are in EMR or EHR 3.0, and hopefully with the enhanced data images, we will use machine learning. We'll have better smart EMRs. On top of that, voice-enabled technology where you are not becoming a glorified typewriter, but at least you are getting meaningful information rather than just the data. So yeah, it's a journey, and pandemic has just augmented all these challenges in those three areas. And as you mentioned, having virtual care, yes, there are some good use cases for virtual care, but it can't be everything. So we are picking and choosing on which the highest ROI will be for the use cases for virtual care, and decreasing our white space, especially in the ambulatory care and wherever we can add our care coordination activities. So yeah, it's an underdiagnosed problem, clinician burden. Just like depression, everybody has it, but you can't diagnose it,
No, it's a great point, Jeet. And so just like Aarti mentioned, how do you know that you're actually targeting and handling and properly getting through clinician burden, and then which of course leads to burnout? How do you guys do that at your facility?
So again, some of it is evidence-based, and some of it is squeaky wheel gets, I mean,
Okay.
crying baby gets more milk or something of that nature,
Right.
depending on the which service lines are impacted. And some of it is true because of your staff turnover, for variety of issues, not getting adequate staffing in certain areas. Um, so I think it's a combination of factor. Although Aarti did mention about the evidence-based, we do have some evidence based on the user interfaces, but we know where the productivity decreases as a result of either per diem staff or the staff which are not the owners, just the renters.
Yeah, makes sense. Jed, especially in your role heading the telemedicine program, you guys have probably gone through, 10 years of learning in a year, just like everybody else had. But one of the things that we've learned over and over again is that if you don't train people, then you're going to have problems with the equipment and the technology and the software. But if you try to train them all the time and they don't use that training, then they forget it by the time that they need it. Where is the balance here of training? Where should you do it early? Where should you do on demand? What have you guys been doing to try to get your staff? And if you can just start with maybe telling us, what percentage of your monthly visits used to be telemedicine before, and now where are you, in that particular journey? And then based on that knowledge now, what are you guys doing about training and workforce development?
Yeah, so we began when I started telemedicine at Jefferson, we were a 3-hospital system. The FTC just withdrew their objections to our next merger, which will make us an 18-hospital system. So for better or for worse, I think I've rolled out telemedicine at more health systems than anybody else in the world as they've come on board. So we've learned a lot. So the first time we rolled it out, we made everybody come to mandatory 2-hour classes. We had 4,000 mandatory 2-hour classes, and we hit 60 or 70% of people, but it made sure they had their picture and their bio and their username and password and knew how to do it. And that was good practice. Now, my staff was from the original area, right? And then we rolled out our next telemedicine program was rolling out in New Jersey. Nobody lived in New Jersey. Half of my staff walks to work. So we said, we better figure out how to do this remotely. So we did that one with basically the same training program, but via Zoom or a remote platform into the practices and took people through the same thing. And we learned, wow, we could scale faster and we could have smaller groups and do more one-on-one. That's great. By the time we got to COVID being launched, we had 1,000 providers that were regularly doing telemedicine, but it was about 1 or 2% of our visits. And in some practices, it was awfully close to 0. And in some practices, it was 30, 40, 50 patients a day. But we went from a telemedicine volume in our scheduled visit program of about 50 a day to 3,000 a day in a week. Mm-hmm. Now, imagine this. Imagine you've learned how to train people remotely, but the untrained people are all the people that refused to do telemedicine for the last 3 years as a system that loved telemedicine, but now it's their only way to take care of patients. So our direct-to-consumer on-demand program, which we call Jeff Connect, we went from 20 visits to 300 over a weekend. The first thing we did is say, we're smart, we know how to train people. We got a film studio. We had marketing get us the film studio, and we went in and we shot a film so that everybody could train asynchronously all day and night. And by the end of that weekend in our on-demand platform, we went from 3 people on call to 20 or 30 people on call and 170 people trained, really 18 hours or 24 hours after we went back into the studio. The problem with all the web-based training, we could do that great. The problem is when it becomes mandatory. So we're talking about burden and burnout, and it seems to me like every 10 minutes I get another mandatory module that I need to do. And I the ones that make me laugh the most are the ones on time management and wellness and burden, right? Because honestly, if I spend an hour going to a time management seminar, I like to say I lost. because
Yeah.
then I just got to do my work later. So it is really finding the right balance and enabling people to get the training they want without forcing them to get training they don't need. Just like Jeet was talking about, if you could cut 17 clicks down to 2, it's a win. And this is, a technology conference, but I have to say it's not about technology. It is about having the right workflows, because I'm an ER doc. And you know what? If I have 2 more clicks to enter the order for an admission, I'd rather have 2 less. But if the doc upstairs doesn't call me back for 2 hours, that is way more annoying than the 2 extra clicks. So we really need to work through the workflows, and we really need to not look at the technology in isolation. We have to say, is the technology solving my problem, rather than, am I just making the technology a little better so it itself is less of a problem?
Yeah, no, I totally agree. And as a longtime product engineer, designer, et cetera, I should be on the end where you guys take sticks and beat me with it, because when we design these things, we're almost always designing it as, nobody ever, like as a software engineer, says, how can I make Aarti miserable, right? But that's where I always end up, is making Aarti miserable. Now, how do I do that? It's because Aarti's not on the team as I'm building this, and I'm going, by the time I've built it all out, and then I take it to Aarti or Jed or Jeet and say, hey, what do you guys think about this? You give me 19 different reasons why something is bad, but by that time it's way too late, right? The software's already been baked, the QA has been done, and we're like, sure, we'll take care of it and we'll put it on our roadmap. Putting it on the roadmap, of course, is secret speak in software engineering world. Like, I ain't doing anything about that. It's coming maybe years from now. But what we do have now is people have learned how to do things that took 5 years in 1 year now. Given that's the case, Aarti, what are the other non-EHR burden reduction techniques, technologies that you're excited about, right? It could be voice, it could be remote patient monitoring, et cetera. Where do you think the burden reduction could be done, burnout could be reduced or eliminated beyond the EHR, if anything?
So I think there's a lot of opportunity, and I would, just go back to what you said and Judd and G said, having the physicians give the problem so you can give the right solution that works in the workflow, because I agree that it all is incumbent upon, is it the right technology for the right problem to be used at the right time? That being said, I do think that for voice recognition, there is a lot of opportunity. And again, we were very fortunate that we had kind of already started our path down that road, even prior to COVID. So we do utilize M-Modal Fluency Direct for all of our physicians. So we allow it as a natural language understanding software and hardware. So it allows the physicians to quickly be able to dictate, pull in key pieces of information, personalized commands so that they can be able to do their documentation very quickly. So while it's not part of the EHR, it definitely does allow the use of the EHR to be more efficient. And just in terms of talking about the huge increase in telehealth, I think that we have seen, even at our enterprise, with New Jersey being hit really hard, especially in the first surge of COVID, that we also had a very similar dramatic increase in the amount of telehealth that we're utilizing. I think our statistics show that we went from like a 90% in-person, 10% telehealth to a complete opposite, 90% telehealth, 10% in-person during the spring. So I do think that we are going to see this hybrid model where people do realize there is a lot of value in being able to use telehealth to be able to, allow their care in more flexible ways. I think paired with that is remote patient monitoring. I do think that people also realize you don't need to come in to get your blood pressure checked in the office, that you can use remote patient monitoring to check your blood pressure. For me, as an endocrinologist, I see a lot of diabetics. So I also see a huge opportunity here. I mean, we've been doing this already with insulin pumps and continuous glucose monitoring. But now to be able to expand that so that you have remote patient monitoring, especially for very vulnerable patients, new to insulin, new type 1s, gestational, we have a lot more opportunity to provide a larger amount of care, but also in the ways that are more suitable for patients in their busy and active lifestyle.
Yeah, and I think that, yeah, go ahead, Jed.
Yeah, I was going to say, I want to add to what Aarti's saying, because all too often we have conversations where we think of it's either telemedicine or a visit, and it's not. And her diabetic patients are a perfect example. It's either they never get telemedicine or sometime they get telemedicine and digital health. And it's really, how can we enhance patient care across the whole care continuum by leveraging telehealth or digital health at the right time or place? Yeah, I'm not an internist like Jeet, but I don't think he wants a blood pressure on his patients every 3 minutes for a year. So, just having digital health isn't great. Having digital health that informs the physician or provider in a manner that's useful for the physician or provider is important. And we're not yet there, but we need to stop talking about telehealth like it's something different. It's just part of the healthcare delivery mechanisms that we have for patients.
Yeah, and I think the reason why we talk about it as something special, partly it's because people need something to talk about. But let's put those guys aside and say, well, why do we say telehealth? We don't say telebanking, for example, when we do internet banking. We don't say telestores when we're shopping on Amazon. So there is something about the fact that telehealth is special. And I think that until we get telediagnostics, which means that the healthcare that I get with me sitting at home and you sitting remote, until I've got my remote unless you got your remote stethoscope, Jeet has his remote blood pressure cuff and Arti has her remote glucose meter. Until all of you have that, I think it's just going to remain telehealth. But so that technology is working when things disappear, right? You don't think about it anymore. It's just part of normal day. And I believe that there's this dichotomy right now of healthcare, where there's a lot you can get done in person. Some things you can get done in person through a video like this, but we have very little or no telediagnostics. And I believe before even jumping to full continuous remote patient monitoring, where you get BPs every 5 minutes, how about you just, while you have me on video, ask me to check my blood, ask me to do my blood pressure check, press the button, and you see it on your screen. That to me is what I refer to as telediagnostics. And I think, Judd, my argument is we're probably going to continue to see this special because we don't get to complete the visit. When I'm on Amazon, I do not have to worry that I'm going to start on Amazon and then I have to end up driving to the store to go do something. No, I start it, work through it, finish it, the entire thing is done. Same thing with my banks and everything else. So I think where we have fixed the problem is where the entire end-to-end transaction is completed online, digitally, et cetera. And I'm guessing we can't really do that at the moment. So Judd, I'd love your opinions on telediagnostics. And then Jeet, please jump in there as well about what you're doing at SBH for remote patient monitoring. Judd,
so I just want to offer a friendly amendment to what you said.
Yep.
This is a wonderful chance for us to reevaluate what is actually really needed for patient care. So I do on-demand telemedicine. That's predominantly what I do now. I used to do, we have a big program that does tele-intake when you come into the emergency department. Everybody insisted that if you're not going to have a nurse in the room and it's just going to be a tech, we needed a remote stethoscope. We got one. It was used 8 times in the first 10,000 patients and then lost, and nobody cares to replace it. Now, we're not sending people home from there who are short of breath, but if you're huffing and puffing, I don't need to listen to your lungs. I need to get you in a room to be seen right away. If you have asthma and you're perfectly comfortable, I don't need to listen to your lungs. You could get your neb and your steroids and wait to be seen in a little while. So at some point, someone may need to do that, but I may not need to do it now. And if you call me because you twisted your ankle in, my on-demand program, I don't need a blood pressure or a pulse. And I can teach you how to feel your pulse counted out loud. So I think it's an opportunity where I agree 100% with you. We need to have the right diagnostic tools in the home to complete the visit, but it doesn't need to be what exists in the office. It's a wonderful chance to get rid of stupid stuff, actually.
Great point, Jed. And this is great input, right? Because I, as a software engineer, believe my problems are X. But when actual physicians get involved, like, Shahid, that's just bullshit. That's not really our problems here. You should be doing something else. So that's awesome. Jeet, can you jump in a little bit? Tell us what you're doing with respect to other technologies beyond EHRs. Is it in telediagnostics? Is it in AI? What are you guys putting into place now to help with the reduction of physician burden and burnout?
Yeah, I think we are in the transition. Maybe if you compare us from the novice to the expert, we are somewhere in between. As Judd and Arti mentioned, there are some very good use cases in pediatrics or chronically ill patients where you can put some devices into the homes, and we are also looking at into the wellness space actually, how we can utilize some of the wearables and to prevent some chronic illnesses. We did some proof of concept here and there with devices in pediatric population with some success. Again, we try 10 things, only 2 are successful, 8 are not successful. So we are still in the transitioning of having from telemedicine, telehealth to fully virtual care, especially in the ambulatory care. One thing I want to add, 2 things actually, regarding the decreasing clinician burden. We serve underserved population in the Bronx with almost 80 to 90% population who speak Spanish, and language interpreter during the telemedicine was a big challenge for us, and that created a big sort of burden to non-Spanish speaking clinicians, which included resident students and whatsoever. So uh, finally we got through the hurdle, and the language interpreter services were incorporated into virtual care. So that was very important for us. So it's not only the tools, but also what are the other complementary things. The other thing I want to add is during the pandemic or COVID surge, we had huge deficiency of almost 30% of our staff got sick actually. And
Really?
yeah, and sick means they were positive. Not everybody were sick to the point that they had to be hospitalized, but they were quarantined for 14 days, 10 days, depending on the CDC guidelines at that time. And we have certain departments or specialty where we have only 1 or 2 individuals. So, and what we did was having a telemedicine between the provider to provider. So that was very helpful for us. And now we are actually thinking that how we can scale it up. For example, we have a shortage of behavioral health providers in our community. So with telepsychiatry, that has been overcome. Similarly, Aarti's field endocrinology, we have a shortage. So how do we complement at least our diabetic clinic, where the nurse practitioners can have a telemedicine through remote. So it's not only between the provider and patients, but also provider to provider. Um, at one point, I recall last year in April, there was a mandate from the state in New York to increase the inpatient capacity by 50%, including ICU. So we went from 40 bed to 110 bed ICU unit. There was a huge challenge for the critical care physicians. So telemedicine actually saved us. We created a pods where internists became, hospitalists became SMI, critical care or intensivist, and there was a telemedicine. So those were some good or innovative way of utilizing the same pool, but different workflow that helped us. And I think it's going to stay for us.
Sure. No, that sounds great. We've got a few minutes left before we're going to open it up for questions. So I just love to go, quick to Aarti, then to Jeet, and then finally to Judd about what are you not seeing being brought to you? I mean, obviously people try, you're senior leaders at your hospitals and health systems, which means people are always trying to sell you stuff. What do you wish you were seeing that you're not really seeing that is being brought to you? So Aarti, we'll let you start. Anything that you wish was being built and brought to you?
From a technology standpoint?
Or any kind of solution standpoint. It doesn't have to be tech. It could be an idea like Jeet was talking about with, telemedicine between providers. But what are people not bringing to you that you wish they were?
I think more interoperability and the ability to gather data from outside sources very easily in a way that's digestible when you're seeing a patient. So in our health system, we have a mix between employed and voluntary physicians. And so some of our voluntary physicians are using outside electronic medical records. And so I think that's one key area where I see a huge opportunity is how do we get the information back and forth easily and in an easy to digest format so that you can, again, not spend the time scanning, downloading, uploading information that should be shared by the same care team.
Yeah, that's a great idea. Jeet, anything quick you want to ask for from the community that you wish they were bringing to you?
Sure. I think we have enough data. But how we can turn this data into a meaningful information, as Aarti was mentioning, that is very, very difficult, and it's not easy to solve when you have so many disparate systems, not only EMR, but ancillary system. So hopefully, as time comes during this journey, if we can create all this data into meaningful information at the point of care for clinician, I think that will go a long way, in my opinion.
Yeah, and so unfortunately, you're going to hear from a lot of vendors and again, software engineers like myself that, Aarti, Judd, Jeet, you guys just need AI. And so the way you guys should push back, you should make fun of people who say that they just need AI. It's like, 20 years ago, if somebody said, I'll be able to fix all your problems because you just need a database. You're like, what? Having a database is not going to help. So AI is like saying, I do molecular biology. Oh, okay, molecular biology is a tool. What are you going to do with it? So I think we need to push back. I think Aarti and Jeet mentioned very specifically, you need to analyze that data better. And of course, machine learning, AI, great tools for that. But if a vendor cannot say what the outcome will be without using the word AI, you want to question that a little bit. So Judd, before we open it up for questions for the rest of the audience, anything coming to your mind about what you could ask for from the community that you're not getting now?
I'm gonna build on what you just said. I want honesty and trust.
Ooh,
I don't. The only thing that I've learned, which is 100% consistent, you're not supposed to say never or always. This is a never or always. Everybody comes to sell me something that's going to, quote, save me money, but nobody can actually save me money. The only thing I know is that they want me to spend money under a premise that something good is going to happen. And all they look at is the cost of their product and what Medicare or commercial payers will reimburse. That is not my expense, and that is not my revenue. We all need to spend tons of time on integration, real hassles, interoperability, and what is the cost of making it interoperable. Digital health, the products have to go out, they have to come back, they have to be cleaned. And my doctor is doing something. So if you charge me $40 a patient and I get 50, I'm not making money unless I'm not paying the doctor or anybody else. Right. So I need you to come to me with what is the real model, what is the true costs, and then how can we work together to develop something that benefits the people that own the product and the people that are going to care for the patients and the patients.
Yeah, that's a great ask from Judd here to just be honest, and which is why we run HealthIMPACT. We want to be a no BS conference. Let's get beyond the BS. There's enough money in healthcare for people doing good, valuable things that can produce outcomes. And so, in this case, one quick example about training is to look at what the airline industry does, where when you get certified for one plane, right? You're flying a Cessna versus you're flying a 737 versus you're flying a 747. That's how you should look at your tools and technologies. Like if you got quote certified or educated on EHR number 1, you change jobs and you go to another hospital to look at EHR number 2. That is a whole different equipment, right? So it's really good to think about that and ask these as the questions as we turn it over now. So I want to thank Jeet, Aarti, Judd, and we'll open up for questions at this point. All right, and if anybody in the audience would like to jump up live, please turn on your video. In the meantime, what I'd love to do is to have Aarti and Jeet really respond to Judd's transition that he made about trust and what do you want from the technology vendors that maybe they're not giving you. So Aarti, we'll let you go first.
So I would love to kind of just dovetail off of what Judd had said earlier, which is to understand not just that when you're providing something and you're saying that it's going to give, it's going to reduce costs, to understand the entire total continuum of cost, because it's not just when you're reducing costs in one area that you may be seeing this significant ROI. It may not just be that straightforward.
And what responsibility, Aarti, then does the buyer, the hospital, the health system in this case, have to report transparently what your costs are? How do you do your workflow? Where a technology provider can come in? So I think it's completely fair to ask what Judd said and what you just elaborated on. But it's unfair if you're not willing to be transparent with where your costs and workflows, et cetera, are. So where does the responsibility lie? Somewhere in the middle?
100% agree. I think that for us, at least, when we're trying to do a vendor assessment, we usually try to go in with the problem and the requirements list ahead of time. So we'll try to bring our end users, our key stakeholders, our clinicians, the nursing, whoever the technology is aimed to help, to the table so that we can really talk through what are the workflows, what are the inefficiencies that we're facing, and how are we trying to solve them. I do think that, as part of that conversation, we can talk about not just operational workflows, but here are also the financial issues that we are facing by doing a manual process. And here are the ways that we think that we can improve upon this by automating something and using your technology.
Yeah, that makes sense. And so, Jeet, from your perspective, and by the way, to the audience, we have plenty of time. We've got about 25 minutes for questions. We wanted to leave this one with a lot of interaction. So again, if you'd like to join us, do turn on your video and come on board. I'm seeing guys like Neil, Sean, Roger, et cetera. I know you guys have a lot to say, so jump on here. So Jeet, I'd love for you to extend on what Judd talked about with the vendor side, and how much should we be transparent from the health system side to help the vendors have that conversation, a meaningful one?
No, I completely echo the sentiments of Judd and Aarti. For our perspective, for at least my own perspective, this is a partnership. Any vendor who are aligned with our single mission, that to provide care, or maybe education, those who are academic medical center. So we have to work as a partner, and without transparency, the partnership can only go a short distance. Healthcare cost in of itself is a little bit complex, but as much as possible, we try to be transparent and make sure that if we grow with our vendors together.
Mm-hmm. And Jeet, can you elaborate then? What is difficult when you're working with outside innovators who have already created a product or a service? I mean, they're not. You're not hiring a bunch of independent, custom chop shop type of folks. You have somebody who's already made something, and they're always trying to sell you what they made rather than what you actually need. So how do you bridge that gap? Like, as an innovator from the outside, that's been my biggest problem. I mean, I've created multiple companies. I'm on my 7th company now. And this is always a challenge, is I've already made what I've made. Will you just please buy what I made you? And in healthcare, that never works. And if you're doing that, you should get out of the industry and go do something else.
Sure.
But there is this place that says, I've got 80 or 90% made. How do I discover that last 10 or 20% to be able to connect the dots?
Or I would say that let's crawl before we do marathon or sprint, and then we walk. My recommendation for these rather small or medium-sized companies, most of the health system across the United States or internationally have a small division, whether under IT or clinical innovation arm. Try to do some proof of concept, understand the workflow. What I understood, majority of these companies are brilliant entrepreneurs. They have very good ideas. Either they don't have data or they don't understand the clinical workflow. So work as a team, make sure that they understand fully the implication, because at the end of the day, this is you're taking care of patients, and there should not be any harm during these interventions. So again, reach out to the chief medical officer if it is a clinical service lines or the other operations. Start with a proof of concept or a pilot and scale it up, and that would be my recommendation.
No,
and amongst us, you see, especially in Northeast, we are small. All the CIOs know each other. So if it works at one place, I usually call up my other colleagues and say, hey, Jack at Montefiore and other institution, that, how are you trying to solve this problem? Or so again, it's a very small world, and we speak to each other and we collaborate with each other. And again, at the end of the day, we just want to improve the health of the community.
Sure. And you don't have a secret blacklist that I'm on, right? Just because I speak to you guys too much. So, Judd, I'd love for you to elaborate on that piece, which is when you're doing this high-speed innovation, there's a lot of folks that have to work inside the hospital with these outside vendors. I think Jeet said the magic word to me, which was team. So this is one thing that I think we're all pretty bad at, and that is, I've got my solution, my friend has his solution, and our friend has yet another solution, and we each come to you independently, right? What is a model that we could start to set up so that as buyers, as the users of these systems, you can tell us, look, I need 4 or 5, 6 things. You guys work as a team, get me all 4 or 5 or 6 of these things together, and then come to me as one. And whoever does that is more likely to get the business than the ones coming independently. Is that silly? Or could you guys give us that kind of input on the outside to be able to say, go team first, put yourself together, then come to me? Is that reasonable? So Judd, we can't hear. 1 second. Oh, we can hear you now. You're back. Go ahead.
Okay. Yeah. So I think it begins with what Artie was saying at the beginning, which, as John Carries, our CMIO, says, what problem are we solving? And then is there something already in our institution that could be tweaked to solve that problem? So when we do our intake, we make it run through a clinical owner. Like, don't come to me and say, I got this great thing that'll help your cardiologist. I don't care. If you can't convince your cardiologist it's worthwhile and make them want to invest their time going forward, I don't need to vet your product. So we actually, have a service line structure with 19 different clinical service lines. It has to be signed off by the head of the service line. Then it comes into a group that, if it's on the clinical side, it assesses the clinical need and asks the question, what problem are we solving, and do we have something that already does this? If it makes it through that, then it gets, full committee review and discussion as to whether we would go forward. But in the ideal situation, I think this is, Jeet and Adi pointed this out, you should design your product. Like, you could build a bookshelves, but I should tell you how many books I want to fit on the bookshelves. And I'm only 5'6". Don't put the top shelf at 8.5 feet. It doesn't work for me. And we should give input onto what you build. But the dirty little secret in all of this that we haven't commented on today is, are we really a team, or are you giving me something free for a couple weeks so that you could run off and make millions and millions of dollars later? And the thing I spend my time on is, how could we structure a deal? Because if you just want me to use it so you could say Jefferson used it, well, then it's a marketing deal and we should be getting something out of it. If you want me to put 15 people around the table and help you design it, there's royalties and equity. We gave you IP. I don't want it free during a pilot period because the integration and upfront costs are a lot. I want to have a long-term deal, and we are truly a team. And the teams I know in team sports, when somebody wins, everybody wins the same thing. They all get a trophy. One person doesn't take the trophy home, say, thanks, you guys stay in the parking lot. We need to develop relationships that are not vendor-vendee. We need to help people build to solve a clinical need. And in return for that, we need to get an appropriate reward for investing in the company to help the company be successful.
No, I love that notion, Judd. So can you elaborate on what you found as you talk to vendors who like or dislike that model, and more to not the founders or the entrepreneurs? My guess is you can probably work something out with them, but what about their investors and others? Do they like that idea of getting diluted for every sale that they make?
Well, it depends on who they are and what they need. And, one of the things that I need to do as a person in my whole life, all of us do, and we need to do with our family and our hospital, is say, what is our value? And if we value ourselves, I got a day job. Jeet and Adi need to keep their home shop alive. If they're doing a deal with a NUCO, they don't get to leave some of their other work behind. So it is actually extra work that either they or their institution should get compensated for doing. And, there's a bunch of different ways to get it. And I'll see a big smile on Jeet and Adi's face. How many emails have you had in the last 3 days saying, could I just talk to you about this great idea I have? That's free consulting, right? We have this insane system where somebody could knock on our door and we'll just tell them everything we know for free. And then we don't have time to do the day job. So I think at the end of the day, a lot of people leave. And personally, okay, because they weren't going to be great partners. And I value my time and my team's time enough that I used to have a signature email, and then I switched programs. It didn't work. My signature email was, for every one of these things, was, you look like your sales rep. If your CEO wants to talk to me and talk about how we could do an equity or royalty deal, I'll be happy to sit and meet with him or her. And 90% went away, saved me a lot of time. The other 10% came to the table. We worked out a deal with a small percentage of them, but we had like really robust, intelligent discussions. And we all agreed if at any point it wasn't going to work, you don't have to finish the hour. At that point, it was in-person meetings. You don't have to finish the meeting. We're on a different page. You can leave. No insults. We like each other. Maybe we'll circle back years later. And we have circled back years later and kept in touch with the people that we had a common vision. But at that point, a deal wasn't right on the investor side. And I would say that's a true partnership. Even the ones we don't have deals, mutual respect. We like each other. We touch base once a year for half an hour. I learn something. They learn something. It's a bi-directional relationship.
I love it. That's a great idea. So, Arti, is that something you could? I mean, I know Judd's the CEO at his hospital. Very much came out of that community. So, is that something, Arti, that you guys could pull off similarly, or do you have a different way of approaching the teaming question?
So we do have things in place, and I think we are moving more towards Judd's model, which is how do we leverage the clinical expertise that we are providing, because I agree that oftentimes we do kind of lay out, these are all of the things that we do, these are all of the problems. We have like 20 people at the table taking time away from seeing patients or providing their other clinical responsibilities. And often with a lot of those times the relationship doesn't pan out. And so a lot of the time and energy that is invested from our end is very valuable to the recipient, but we don't necessarily end up with the deal or the technology that we were sitting at the table to discuss. So I do think that we've started to look at how do we create partnerships, joint ventures, equity stakes especially in the earlier stage companies or companies that are looking to develop clinical workflows, clinical platforms, like especially in remote patient monitoring and things like that. So I do think that we are on that path. It sounds like at Judd and at Jefferson, they're maybe a little bit further along. But yeah, it's very interesting and agreed. I think that a lot of times we don't value what we're bringing to the table. And so it's nice.
Yeah, no, I completely agree. And I think that as you think about this, why this matters for smart technology to help clinician burden is often introduced, staff burden is often introduced because of misalignment of what I made as a product and what you need as a health system. So if that is misaligned and people make the wrong decisions about how to purchase and how to deploy and how to install, well, then Cruft sits on top of a bad workflow, and then we do something stupid, and then we do something dumb on top of that. And then you find out, 6 months later that the situation is much worse than it was before the quote innovator came along. So this is really, really important, is how you buy and how you identify the technology. So Jeet, any comments on what Judd and Arti mentioned? How do you buy, and what do you like to be the relationship and the teaming that you yourself brought up as a topic?
I think similarly like what Judd has mentioned, we do want to be partner, as I mentioned earlier. One thing I want to have suggestions or recommendations for all these innovators and entrepreneurs. Look at the infrastructure. If you're developing a clinical solutions, look at the infrastructure first. Are these EMR for a long haul? Because if you are at Epic or Meditech or Allscripts or Cerner, you want to understand that these are not for 2 or 3 years solutions. These are for at least 8 to 10 years, number one. Number two, do not create a solution which will be shadow IT. You need to create a solution which will be, like Arti earlier mentioned regarding the interoperability. I come across so many different systems which are boutique systems, and they don't even talk to our main framework. So yes, you can go to GI doctors and say this is one of the sexy endoscopy reporting system, but it's not going to work in our system. So again, for most of the clinical systems, I would recommend that to understand the infrastructure of an existing EMR. Obviously, that is the most important clinical application, and then try to make sure that these are fully integrated or interoperable.
No, I love it. And so we have to you have to wonder, for example, the buyer is supposed to hold all the power because you're the buyer, you're going to deploy things, et cetera. But often the buyer doesn't hold the power based on how its decisions are made. So if the C-suite is able to make any decision, all I have to do as an entrepreneur is go to the C-suite, wine and dine them, take them out to play golf, et cetera. Famously, there's a lot of places that happens. What happens at a hospital? How do I go from the top down? You mentioned you don't want shadow IT, but I know as an entrepreneur, if I can do shadow IT, I get inside, I get stuck at the hospital. And now you, Jeet, as a CIO, have to find a way, if I got stuck with the right physician who has the preference and the power. Shadow IT is way too powerful to not do for an entrepreneur. So what could you offer me as an entrepreneur to say, okay, don't do shadow IT. There's a proper way of getting in, and you're not going to get stuck in a 6-month cycle of me sending you around to a bunch of people to go talk to. Because as entrepreneurs, even if we're going to partner, like I love the idea of partnering and offering both equity or options or warrants, all kinds of stuff could be offered in terms of benefiting you to make sure that the burden after the introduction of my technology is limited to none. But Jeet, what do you give me in return so I don't go do shadow IT, which is much easier?
So you know what? Also, it depends upon the priorities. If there is a regulations, for example, we had to do these thermal kiosk and COVID questionnaire. Time was of essence, so we didn't have so much leverage. So if you have those kind of solution, the priority is pretty fast. But for other clinical solutions which are not regulatory requirements, is just to have feel good or improve some efficiency or productivity, then they have to go through the proper channel. And we have a very strict governance structure. So shadow IT only can take you so far. And,
yeah, that's a good point. And that's a good answer, right? So if shadow IT makes you feel good as an entrepreneur that you're being used, but it's just because a physician likes it or doesn't like it, doesn't mean it's going to go higher. Well, that's antithetical to me. Is I don't want the shadow IT, because if it makes me look bad in front of the people that are going to actually pay for it, that's different. Now, there is one kind of shadow IT which before the 2010s, before Dropbox, before Box.com, and other technologies and innovations that grew from the ground up, the business to business type of bottom up type of technologies. Before that happened, everything happened top down, because you had to have things on-prem installed behind a firewall, behind the network. So there was no way to get in. There was no shadow IT because there was no way to get in. Correct. Today, post-cloud, it is not only possible, it's actually very easy to get in, but I guess staying in it becomes the question. So Jed, do you want to comment a little bit about this shadow IT? Because if you have burden, if let's say you on the staff, on the CEO side, C-suite side, are creating burden on staff, but staff have the ability to alleviate the burden by going to an external supplier, like me, I've got a super cool idea. You go out to me. How would you feel about staff going out and looking for solutions outside of the normal boundary that you create?
Well, it's a little bit of torture, isn't it? And I'll tell you, we had a very well-founded telemedicine program. We'd done over 100,000 audio video calls before COVID ever hit. So, we did a lot of this, but, and a third of the enterprise was doing it all the time, or a lot, and a third was doing it periodically. And the other third, they weren't late adopters. They were, I don't ever want to do this freaking thing. And then they had to. And so they wanted the most frictionless thing they could do, which might be FaceTime, might be some other brand names that I don't want to berate, because they were there to solve a problem for people that needed it solved. Some with some really, really super aggressive marketing strategies, one doc at a time, that, we weren't going to support from a telehealth or IT side. And they're not, approved telemedicine platforms. And again, we had a long-term strategy, and we had a long-term partner, and we had a long-term solution, and it worked. If you took any of the 8,000 training classes we had in the last 4 years, or the 4 we had every day for the month before COVID hit, but people found workarounds. And so we started just monitoring who was using the workaround, because if you weren't using our platform, but you were billing, i.e. there's a record in the EMR, it's pretty hard to figure out you're using something else.
Yeah.
But on the other hand, we had to work with our partner to say, these guys are finding this easier. How could we make yours easier? And they did. And so it was really fruitful. So you can learn something even when you're working with the established platforms from some of these fly-by-night people that are just startups that weren't necessarily HIPAA compliant and weren't necessarily secure channels. So I think we tried to keep tight reins on our long-term strategy, but yet learn from the friction points that the docs pointed out to work again with our true partners to improve their own product. And we were fortunate. We had real partnerships where we sat at the table in development time and were able to work through this.
So Judd, where are the areas that you're pretty sure you can still eke out some efficiencies to reduce more and more burden with smarter and smarter tech? Where do you wish the incumbents or others would go that they are maybe not? Are some solutions not coming to you that you wish were coming to you?
So the thing I would like most, and again, I'm approaching this really from the telemedicine land and not all of the digital health and AI and and interpretive services, is I want real-time monitoring. I want to know that I'm looking at a dashboard and oops, Artie's on a call and she can't see the patient. Oh, the patient's on Safari and they need to be on Chrome and be able to text the patient and intervene. I really want that overall mission controlled dashboard, because we know internally in our own data that 75% pre-COVID, 75% of physician-patient interactions were driven by the physician. So we all want the patient to have a better experience, but if the physician is complaining about it, the patient experience is gone. So we know we need to drive the patient experience through the physician to make it good. And really, patients, it flickers on and off. They don't care. They got their medication for whatever. They're happy. The physician, it flickers on and off. Oh my God, your whole platform's horrible. Why do I have to do this? And so we actually have a really intensive monitoring program that then everybody complains about. Like at the end of each visit, it's 2 clicks to check the quality of what it is. And then we could go back and pull the files and see what browser and where you're located and what the issue is. And nobody wants those 2 clicks. So really, I want to make it so I don't have to rely on my physicians to give me feedback. And I have mission control. It could tell me how things are going by area, because we know our hiccup rate is greatest around our biggest high school if people are taking calls from home, because all the kids are on Zoom, right? And the teachers are on Zoom. Like, who would guess? But I need to know where my docs live, where my patients live, in order to control my hiccup rate. So mission control is my answer.
That's fantastic input. And by the way, it was all free just for coming to Health Impact. That was great advice. Arti, we've got a couple of minutes left. I'd love for you to talk about that same question, which is, what are the areas that you could reduce some clinician burden, like Judd just mentioned, but maybe people aren't coming to you with those ideas that you think that they should be?
Great question. So again, I think this is something I had touched on a little bit earlier, which is how do we get the data that we need from disparate sources to come into our health record easily and in ways that we can access it while we're seeing a patient in our workflow. So I think that there are technologies that, like we've talked, all of us, I think, have already mentioned, that we are able to solve the ability to get certain information in. It's then, what about the interfacing? Where does it show up in the medical record? How do we access it? And now are we asking our clinical team to look in 10 different places as opposed to 5 just to get one more piece of data? Mm-hmm. So I think for me, it's how do we get all of the things that we need to make a really good clinical decision in the right place at the right time?
Yeah. So now the only dichotomy between what you just said is, and getting to a solution, is that there will be pockets of small providers who can give you some of that, rather than your big vendors who already are there. They're making tons of money on you guys. They're quote fat, dumb, and happy. Like, I love those because that's the businesses that I like being in. Is I'm already there. I've been there for 20 years. I'm not going anywhere. Those are not the guys that are going to give you all the stuff that you want. But you're afraid to use the smaller vendors. So what do you actually do here? How do you set up a teaming environment with your current incumbents? And this is not just the Epics and Cerners of the world. Incumbents are all over the place in hospitals. So Arti, what would you suggest for innovators who've got these ideas to come and give to you to work with maybe your incumbents? Is that something you guys could make the connections for in return for options, warrants, et cetera? Or what would you think is a good way to work with them?
Definitely, and I think that Judd had said this before, Jeet, that what we often try to do is start with what's the problem. So looking at our current landscape and seeing, are there ways to tweak what we already have? And if we can't see that there's a way to easily manipulate the technology that we have, then I definitely think creating a partnership between obviously our incumbent technology, which we're not probably moving away from, especially some of our larger vendors, but to utilize some of like the more nimble startups to see, okay, how do you fit in seamlessly with what we're already doing, but to fix the issue. And again, I think it always goes back to I really clearly identifying what the underlying problem is, what's the inefficiency, and what is our, like if we had to say this is our optimal solution, knowing that going in, so that when we actually view what the new technology is, we could pair it up against, okay, these were all of the requirements we had already outlined before we went to go speak with someone.
Yeah, that's great. So, Jeet, we've used up our hour. Is there anything else you wanted to say right before we close up here?
No, I think my colleagues, they summarized it very well. And no other comments.
Awesome. No, this was a great conversation. I know that people are going to hear more of this in the recording, and hopefully you'll get a lot of discussion points coming in, especially Judge. You'll be just sent lots and lots of requests to have people own parts of them and get installed at Jefferson, apparently. So that's great. Aarti, thanks so much. Jeet, thanks for coming here, giving us your wisdom, and we'll see you at the next Health Impact. And for everyone else, please join us at our next session. Thank you very much. Bye, guys.
Thank you all.
Thank you.